Right, I think we'll make a start. It's dead on 12 o'clock. Thank you to all of those who've taken the time out of your day to join this afternoon session, which is the second chapter in our series of Prepare to Heal webinars, which focuses on wound preparation. My name's Ellen Buckley, and I'm one of the tissue viability nurse advisors working with Coloplast. And I'm really excited to share with you some insights into wound preparation and how we can make things a lot simpler for our patients, for ourselves, and improve those wound healing outcomes. So without further ado, I'm going to share my screen with you so you can see the presentation. During the session, I won't be able to see the chat function. But my colleague Charlie, who is on the call, one of our other tissue viability nurse advisors, is going to monitor the chat. So please keep your questions about any of the slides or any clinical challenges that you have in relation to wound preparation, wound debridement, any issues that come into your head. Charlie will endeavour to answer them as we go through the session. For any of you who were unable to join the first chapter in our Prepare to Heal series, which focused on wound assessment, but you registered for the session, you'll still be able to view those recordings on our Coloplast professional website, and I'm sure again one of my colleagues will be able to put that link to that website or that platform in the chat function, so you'll be able to see what happened during the first chapter. So again, without further ado, our session this afternoon focuses on wound preparation. And how we think about wound preparation may differ from clinician to clinician. How we carry out wound preparation might differ. What our thoughts are about what wounds do and don't need to be prepared, and what methods we use to prepare our wounds to make them heal or help them along that healing trajectory as quickly as possible. And essentially it's all around removing those barriers to healing. That's what we need to start thinking about and changing the way that we view wound preparation. So what we're going to cover during this afternoon session is how we simplify our approach to wound management and wound healing. Have a think about the different terminologies we use around debridement, around wound bed preparation, around wound preparation, wound cleansing, wound washing, for example. What is it we mean by all of those different terms? Again, as I said, we need to think about why wounds need to be prepared. What difference does it make if we prepare our wounds really, really effectively? Have a think about what different methods of wound preparation we have available to us, and maybe there are more methods available to us which are simpler to use than we previously thought. So again, changing the thinking around wound preparation. What impact does wound preparation have on wound healing? Is it positive? Is it negative? And thinking about again which wounds that we perhaps have on our caseloads that would benefit from implementing a more robust and effective wound preparation as part of that patient's pathway. And we'll have a look at some wounds which you can have a think about yourselves, whether you would or wouldn't consider debridement or wound preparation for those wound types. Coloplast, as I said, we like to keep things simple. So much in life is so complex. We don't always have the time to complete really complex wound assessment tools in our documentation when we see a patient and do an initial assessment or reassessment of a patient's wound. So we need to make sure that we're using very holistic and simplified frameworks to facilitate that process. And the first step, which is what we focused on in our first chapter within Prepare to Heal, is around step one, which is the assessment of our patients. And Coloplast developed, in conjunction with other wound care experts, something called the triangle of wound assessment, which is a holistic framework, as you can see here on the slide, that helps practitioners not only comprehensively do an assessment of their patient and their wound, but look at it in a simplified way, so focusing on both the wound bed, the wound edge, and the peri-wound skin. But the triangle of wound assessment also helps us to identify healing objectives. What is it, if we've identified devitalized tissue, for example, on a wound bed. What is it that we're trying to achieve? What do we need to incorporate in our ongoing management of that patient to deal with that barrier to healing? Step 2, which is what we're focusing on today, is around preparation of the wound. And what we now know is that effective wound preparation can have a massive impact on how long that wound takes to heal, and also overcoming the factors for the patient and the challenges that the patient has in that wound being there in the first place, and for the length of time that wound takes to heal. We want to remove those potential barriers to healing that are pertinent to that patient and that patient's wound. And certainly effective and simplified wound preparation can be a goal, can be a method in achieving that goal that we set out. And if we don't do that effective wound preparation, the treatment that we implement for our patients can often be not as effective as we intended it to be. And Coloplast have a wide range and portfolio of dressings which are simple to use for patients, if patients are taking part in their own wound care, but simple for clinicians and quick and easy to use. So that's the Coloplast 3-step approach. And as I said, this afternoon session focuses on step 2, which is around wound preparation. I'm sure all of you on the session this afternoon can identify with some of the challenges that you can see in the images, in the clinical images on the screen, whether that be a wound that has excessive amounts of fibrin or slough on the wound bed, whether there be some undermining to the wound edge, like you can see in that image on the far left of the screen, whether it be that the wound bed is filled with necrosis or slough, devitalized tissue with some signs of localized infection that you can see in this image here. We can't see what's going on in the base of this wound. Any dressing that we apply to this wound to facilitate that wound healing possibly isn't going to be as effective as it could be unless we do some really, really effective and robust wound preparation to remove all of those barriers towards healing. And that image on the right hand of the screen shows a patient's leg with some significant hyperkeratosis, so that excessive build-up of keratin and dry skin on the patient's leg. And again, any treatments that we use on this kind of skin, whether it be very close to the wound edge or on the peri-wound or surrounding skin, is going to be, again, a potential barrier for that wound to progress to where we need it to be. So we need to look at all of these individual challenges that are really, really common in the patients that we face on a day-to-day basis. These are some anecdotal things that clinicians have said around their feelings about wound preparation or debridement. Some people feel that if they do any cleansing of that wound, then it can potentially, disturb the progress of the wound. They don't want to cause any damage to that wound, any new cells and any new blood vessels that might be developing as part of that angiogenesis in the wound healing process. Some people feel that if they clean or wash the wounds, that the wound temperature will drop, and again, it can slow down that healing process. Some clinicians were always taught to only cleanse the edge of the wound, not to actually touch the wound bed or that surrounding skin, for fear that they're going to cause excessive trauma by disturbing all of that new tissue that's growing. And these are just some anecdotal things that clinicians will say when you discuss wound preparation with them. But we know that wound preparation is so really important for patients, and really should form a really integral part of the whole wound management plan for that patient, because we know that optimization of the environment of the wound, not just the wound bed, but certainly the wound edge and definitely the peri-wound skin, reduces bacterial load. It removes any debris and foreign bodies that might be on that in those areas, and it can also disrupt and prevent biofilm activity. We know that slough or non-viable tissue and biofilms can all delay the wound healing process, because they will certainly increase the risk of infection for that patient's wound. They can inhibit the development of that new healthy granulation tissue that we really like to see as our wounds progress towards healing. And often as with that middle clinical image that we saw on a previous slide, you can't see what's going on at the base of the wound because that devitalized tissue is blocking your vision, it's blocking your view. So it can certainly limit wound assessment. You might not be able to even measure the dimensions or depth of that wound because you're prevented from doing so by all of that that non-viable tissue sitting in that wound bed. So we need to have a think about those issues as well. And delayed wound healing can lead to, decreased quality of life for a patient. I mean, it's bad enough having a wound, as I'm sure you will agree, it's bad enough having a wound there in the first place, but for a wound to be there for an unnecessary extended period of time can certainly decrease patients' quality of life, whether that be through pain experienced by the wound being there that the patient might have. It might be excessive leakage, the dressing needing to be changed more often, so therefore more appointments, more visits from a community nurse potentially. Malodour is a significant issue with a patient with a hard to heal wound. And wounds that are there for an extended period of time take longer for us to treat. Some of the methods or some of the dressings that we use can be quite complex and timely to apply to a patient, so therefore would have extended visit times or extended clinic times. And certainly the whole burden of treatment for that patient's wound can be increased the longer that wound is there. And I'm sure you can identify with that. And time costs money, as the saying goes. So we do really need to think about this in financial terms as well, not just in how long it takes for that patient's clinic appointment or how long it takes for that clinician to be in that patient's home to do that wound treatment, but all of the different dressings and treatments that we use to try and progress that wound towards healing. It all adds up in the total money that is spent throughout that patient's journey. So just to recap, and I don't apologise for recapping and going on over and over again about the importance of removing devitalized tissue from a wound, because it is such an integral part of that whole wound healing process. We really need to pay more attention to it than we currently do. We know that devitalized tissue, as I said, increases healing time for that patient. The body will take longer to get rid of that devitalized tissue without intervention. It can increase the risk of wound infection. The longer that devitalized tissue stays within that wound bed or on that wound edge or in the peri-wound skin, it's like a playground for bacteria. It's where they like to live. It's wet, it's warm, and it's where those bacteria will proliferate. So we need to reduce the opportunity for those bacteria to do that within a wound. It can prolong the inflammatory response. So as long as there's an increased bacterial load within that wound, the wound can often stay in a vicious circle of inflammation or prolong that inflammatory response, as we see in the wound healing process in wounds that are difficult to heal. But we'll touch more upon bacterial activity a bit further on in the presentation. And if we remove devitalized tissue, we have the opportunity to increase the levels of these pro-inflammatory cytokines, and these are what we call signaling proteins that are really, really fundamental in wound healing. So removal of that devitalized tissue facilitates that happening for the patient as well. So how will wound preparation support wound healing? As I've said, it will reduce the risk of infection by removing those physical barriers, getting rid of that playground for those bacteria to have a field day in and enjoy themselves. We don't want them to enjoy themselves. We want them to help to go away, to be killed, and help that wound to heal. We can improve healing outcomes for patients. We can shorten the length of time that that wound is there by creating that optimum level of healing or that optimal environment for that patient's wound. We can often improve pain levels for the patient, because often, things like maceration is linked with increased pain levels for patients. So if we can reduce the risks of that happening by effective preparation of the wound, then that can only be a good thing for improving that patient's quality of life and reduce the time that that patient spends living with that wound. And it's been clinically proven that cleansing and debridement actually does speed up wound healing. And this graphic you can see here on this slide is an example of a study that was done for a diabetic foot ulcer. So it comes from a 2013 study where they compared diabetic foot ulcers that were cleansed once every 2 weeks and diabetic foot ulcers that were cleansed once a week. And you can see here that the healing time is hugely different for those that were cleaned more frequently. So this evidence shows us that the more frequent that a patient's wound is debrided and prepared robustly, dramatically reduces the time that wound is there and exists for that patient. And that's a really, really important study. So by effective cleansing and debridement of the wound, we can really remove those barriers to healing that we've discussed, such as slough, non-viable tissue and biofilms. We often use the term debridement, wound bed preparation or wound preparation interchangeably. And different clinicians will refer to it as any of those different words, really. But we're actually given a definition of what it is we mean when we talk about wound debridement and what it is we mean when we talk about wound preparation. So the term debridement is actually the physical removal of that dead or devitalized non-viable tissue. It's the physical removal of those infected or foreign bodies within the edge of the wound or within the wound bed itself. But when we think about wound preparation, we're thinking more about a more holistic, systematic concept of how we approach the assessment of the wound and how we remove those barriers towards to healing, allowing that wound healing process to progress normally. So they're the definitions that we work towards. But as I say, people will often use these terms interchangeably. It's so important, and as I said, and I keep saying, it's a fundamental part of that patient's wound management plan. We know that dead and devitalized tissue will create a physical barrier. It prevents those epithelial cells migrating across a wound. Wounds heal from the wound edge, so epithelialization will take place from the edge of the wound. So we really need a good, healthy wound edge to allow that process to happen. So it's really important not just to focus on what's happening in the wound bed, but to take it to encompass in our assessment and in our management plan what happens at the edge of the wound and on that surrounding skin. You can see in this image here, the edge of the wound isn't particularly healthy. It's very dry, and the surrounding skin is also dry and scaly, and that they are potential barriers for this wound to be able to progress to where it needs to be. Benefits to the patient, I mean, it goes without saying, and you can sort of, see from the things I've already said that, wound preparation is definitely of benefit to the patient in relation to the potential reduction in malodor and the reduction in exudate. If all of that devitalized tissue is removed quickly from that wound bed, edge and peri-wound skin, then there is less likely to be excessive exudate coming from that wound. Which could cause a problem for that patient. We reduce the risks of infection and all of the challenges that has for patients, and we can improve healing times. That patient can have that wound for a shorter length of time and have much improved outcomes than if that wound hadn't had effective wound preparation. This document was published last year, and it's essentially an expert panel of wound care experts who wanted to look more in depth at wound preparation and what it is that we actually mean, because lots of different terms are used when we talk about wound preparation. And if you look at the green end of this algorithm, we talk about wound washing and wound cleansing. And these aspects of wound preparation don't necessarily require any extended competencies and training. And essentially, we're removing the loose surface contaminants, debris, bacteria, any excess exudate and remnants of old dressings that might have been used previously for that wound, for that patient's treatment from the wound bed, the wound edge and the peri-wound skin. And then we move to the pale blue aspect of the algorithm. We talk about things like autolytic debridement, mechanical debridement, biological debridement, and enzymatic debridement. These don't also necessarily need extended competency and training, but the clinician who is carrying out these aspects of wound preparation need to have greater understanding about what these different products are doing, what method am I using, why am I using it, and how is it going to be effective for my patient. And then we move towards the dark blue end of the algorithm, where we talk about sharp or surgical debridement using a blade, essentially. And as you would imagine, this type of debridement in your patient's wound management requires extended competency and knowledge in the skill by the clinician who is intending to undertake that procedure. So just to delve in a bit more depth about the different types of debridement, some of which we've touched on slightly. So firstly, autolytic debridement. What is autolytic debridement? I mean, autolysis is the process that the body goes through by itself during the wound healing process. The body wants to regain all of those functions of the skin that were there before that wound existed. So the body itself tries to expel and get rid and liquefy all of those bacteria and all of that non-viable tissue. And if the body itself knows that these things are a barrier towards healing and it wants to get rid of them. And all of the dressings that we use to do the wound management and treatment for our patients basically work on the principle of autolysis and moist wound healing. They create the right humidity and atmosphere underneath the dressing to help the body go through that process a little bit quicker. They essentially add moisture to all of that non-viable tissue to get the wound where it needs to be and progress it along that wound healing trajectory. And this is the most common form of debridement that we use today. And then we think about biological debridement. So this is very popular. It's essentially the use of maggots, which are grown in a sterile environment, which are applied to the wound bed, and the maggots will digest the devitalized tissue and the dead tissue that sit within that wound bed. They're very, very effective. And have been used more and more in this current day and age to facilitate that healing trajectory in a quicker period of time, because they will do very quickly in 3 to 5 days what your moist wound healing dressings will take much longer to do. And we talk about enzymatic debridement, and this is performed by the application of a chemical agent, and the chemical agent within this treatment will liquefy the dead tissue, the necrotic tissue, with enzymes to help remove them from that wound bed, again, to get the wound on its healing trajectory. Mechanical debridement, the most traditional method of mechanical debridement, involves something called the wet to dry technique, where wet gauze is applied to the wound bed. It's allowed to dry out, and then in doing so, it adheres to that devitalized tissue on the wound bed. And when that dry gauze is removed from the wound bed, it tears off or it removes all of that devitalized tissue with it. It's not very well accepted by patients because of its association with pain. And we have much newer and more modern methods of mechanical debridement available to us, which don't carry that element of pain in removing that devitalized tissue. And they're more accessible. These newer methods of mechanical debridement are more accessible, much simpler to use than traditional methods. And then we talk about sharp debridement or conservative sharp debridement. And as I said before, when we looked at the algorithm in the best practice recommendations, it's around the removal of dead or devitalized tissue using a blade. So that being maybe a scalpel, it may be scissors, with or without forceps, to just above the viable tissue level. It doesn't result in total debridement of all of that non-viable tissue, and it can be often used in conjunction with other methods of debridement, such as autolysis or moist wound healing that we mentioned earlier. But as you can imagine, because of the level of risk associated with sharp debridement, extra levels of training and competency need to be achieved before the clinician decides that this is the method of debridement that they want to use for their patient. Now I'm going to ask you now to join in with us, engage with us in the chat function. As I said, I can't see it, but my good friend Charlie is going to be monitoring the chat function to see what your answers are to these questions. So I would like you to have a look at all of these wounds, and I know that Charlie is going to put a copy of this slide in the chat function for you to have a look at these wounds and consider which of these wounds you feel should be debrided, and possibly even what methods of debridement you would normally use to get rid of the devitalized tissue within these wound beds of these different wound types, at the edges of these wounds and on the surrounding skin. And we'll come back to this at the end, just so we can have a look at what your thoughts are and what methods of debridement you currently use, and whether your thought process might have changed as we've gone through the presentation. So how often should we do wound preparation? Well, what we want to do is to accelerate healing or facilitate the effectiveness of the dressings that we are using for the wound management of this patient within that patient's treatment plan. And really, we need to be doing wound preparation at each wound care intervention. And that might seem a bit alien to some people. And you might think, well, I do wound preparation, you know, I use my gauze and a bit of sterile water or whatever when I remove the dressing. But really, how effective is that wound preparation in getting the best out of the dressing that you are going to subsequently use for the patient? But essentially, it's something that should be done based on your assessment of that patient, what you can see in the wound bed, I mean, at the wound edge and on the peri-wound skin. But bear in mind, we can't see with our naked eye all of the barriers to wound healing. Some barriers to healing we can't actually see. So biofilms, for example, are too small for us to see. So the wound may appear clean, if you like, on the surface, but actually there could potentially still be some issues with biofilms causing barriers to healing. It needs to be done on your clinical judgment, depending on what your treatment goals are following your assessment. What objectives for treatment have you decided following your assessment? And obviously what method of wound preparation you use will depend on your pain level for that patient as well. So can it help us assess? Well, absolutely, it can help us assess wound preparation can help us in our wound assessment. So if we implement a really robust wound preparation plan as an integral part of the patient's overall plan of care for their wound, we can see that the formation of healthy granulation tissue will definitely be optimized, and the efficiency of any other therapies that we use will be improved, and again will ultimately reduce the time it takes for that wound to close. Removal of that non-viable tissue, the debris and the bioburden will facilitate the optimal wound healing environment and will help a clearer assessment of our patient. And if we've got a clear assessment, then it can help us decide on which simplified method of treatment we decide to use to meet those goals that we set out for with our patient. We want to overcome those physical barriers to healing at the wound bed, the wound edge and the peri-wound skin. And again, I make no apologies for repeating myself. Let's not have our blinkers on just looking at what's going on the wound bed, not just looking at that little bit of necrosis or that little bit of slough that we might see. We need to pay real attention to how healthy our wound edge is and how healthy the patient's peri-wound skin is. But sometimes we need to be cautious with wound preparation, and these are just some situations whereby you may want to execute caution in your method, or on whether you debride or prepare that wound at all, or what method of wound preparation you decide on for that patient. So if the patient that you're assessing has a wound on the lower limb and the patient is known to be diabetic, have a diagnosis of diabetes, the wound may still be suitable. The patient may still be suitable for different types of wound preparation, but you may feel it more pertinent to get specialist advice for the patient if you're unsure. If a patient has known arterial compromise on their lower limb, which would mean that there is poor perfusion to the tissues behind that wound, so there isn't enough oxygen and nutrients to facilitate ongoing healing. Again, that kind of patient may not be suitable for certain types of wound preparation. Or if the patient has impaired healing ability because of different medications that they may be taking, or different underlying medical conditions. For example, if the patient suffers with immunosuppression and has an increased risk of infection, or if the patient has taken medication which is cytotoxic, again, we may need to execute caution with this kind of patient too. Let's talk about biofilms, which I touched on. Well, I've touched on it a couple of times, but just to have a think about, what is a biofilm and why is it important? So essentially, biofilms are structured communities of microbes with genetic diversity. So not always just the one type of pathogen. So it might not always be a Staphylococcus aureus microbe that's in the wound bed. It might be a Staph aureus microbe along with a Pseudomonas pathogen as well. So they will have genetic diversity. There can be different types of microbes that might be causing us a problem. And they live in structured communities. They are protected within that wound bed, not just on the surface of the wound, but beneath those wound tissues as well. And they're given protection by that devitalized tissue that's there. That's where they like to live. That's where they like to hide. And that's where they're going to have the parties I keep talking about. So they can cause a real problem in wounds that are difficult to heal because we can't often see them. In fact, the biofilms, what you can see within the wound bed is the devitalized tissue. They aren't the biofilms. The biofilms you can't see. So 80%, what we know is 80% of non-healing wounds contain biofilms. So there is a chance, if you've got a patient with delayed healing, that biofilms could be one of those issues that's causing the problem. But signs of infection can indicate the presence of a biofilm, whether it's just delayed healing, where you've excluded all other factors which may influence that patient's healing potential. There might be increased exudate or an increase in slough. There might be an increased inflammatory response for that patient. You might be seeing more and more signs of localized infection, such as erythema or redness, malodor, all indicating that there's a high bacterial load. And we get this chronic vicious circle of inflammatory response. So as I said, a non-healing wound which has devitalized tissue is a real ideal environment for biofilms to form and to hide and be protected. And if those biofilms are protected, it doesn't really matter what dressing. We might have the most fancy, silver dressing or whatever it is that you're trying to treat that infection with. If those biofilms are protected by that devitalized tissue, the dressing isn't going to be as effective as you intended it to be. So therefore, you're going to need it to use it for a longer period of time without the true effects that you're intending. So we need to think about the devitalized tissue that's on that wound bed. The biofilms being there cause this chronic state of inflammation. So the body is trying to fight these biofilms and trying to kill them by itself. And we get that chronic, those signs of inflammation that we see when the body is developing infection, and it's there all of the time. And that chronic inflammatory response, again, brings us back into that vicious circle, because if you've got chronic inflammation, there is a risk of more or further tissue damage within that wound bed itself. Again, given those biofilms the ideal opportunity to be protected and to proliferate even more within that wound, a real barrier towards wound healing. The International Wounds Infection Institute give us guidance about what is best practice for management of biofilms, and it's a three-pronged attack, if you like. It's a three-step approach about how biofilms should be managed for our patients. You can't just implement one of these stages. All three, to have the effect that you want, need to be implemented for the patient. So we need really effective wound preparation. The wound needs to be cleansed and debrided to reduce the number of microbes that are causing that problem, that chronic state of inflammation. We need to upset those microbes. We need to annoy them. We need to remove their protection and help remove some of those biofilms from the wound surface. We then, once we've done that, and we need to do that frequently, it can't just be a one-off thing. It needs to be frequent, as we saw in that Wilcox study with the diabetic foot ulcers. We need to be continually using effective wound preparation and debridement at every interaction with that wound. And then once we've done that, we need to be applying a barrier dressing. We need to have a dressing that is really effective and at absorbing the exudate in a really effective way. It needs to absorb the amount of exudate that the wound is exuding. It needs to be able to stop the exudate pooling on the wound bed. It needs to prevent maceration at the wound edge, so because of the way that it absorbs the dressing. It needs to conform to the wound bed to reduce those pockets and those pools of exudate. And we don't want that wound to be recontaminated. So it needs to have the ability, the dressing, to hold that exudate in to stop it going back into the wound bed and continuing to cause us a problem. And then infection management. We need to have the dressing that has an active ingredient that will donate that active ingredient within those wound tissues themselves. We don't want that antimicrobial to have to work too hard to kill those bacteria. We want it to be able to, we want that active ingredient to be where it needs to be to meet those microbes before they start to cause too much of a problem deep within those wound tissues. And that's from the Wounds Infection Institute. So frequency of preparation in management of biofilms. We still need to do more research to establish how frequently we need to do debridement, but expert opinion that it should be performed at least once a week. And as I said, not just when you can physically see something in the wound bed or at the wound edge, because you can't often see the barriers to healing. We need to be using it to disrupt those biofilms frequently to prevent those biofilms reforming, because they reform very, very quickly. It's been demonstrated that, you know, debridement gives us a window of opportunity where those defences are interrupted of those biofilms, and it makes that dressing that we then apply to kill those bacteria more effective. I'm going to talk you through a case study about a patient here. So this is Mr. D, and he is a 55-year-old male who had amputation of his left big toe. He was diabetic, and he had an element of arterial compromise to his left leg. Multiple dressings changed every day were used to manage the exudate that was coming from the wound. So after wound assessment, where we were, aiming to create the optimal wound healing environment, it was decided that we needed to prepare that wound bed effectively, and the edge of the wound and that peri-wound skin. So our management objectives or goals were to remove that non-viable tissue, to manage the exudate effectively, to kill those bacteria and reduce the bacterial load for the wound as well. We also wanted to protect that granulation and epithelial tissue, and we wanted to protect the surrounding skin from any damaging exudate that was coming from the wound. So that was our assessment and the management objectives we decided on. And then for wound preparation, we introduced a product called All Prep Pad, which is a mechanical debridement pad, which is very simple to use, and it's used in a way that is massaged over the surface of the wound bed itself, the wound edge and on the peri-wound skin, to disrupt those biofilms, to dislodge any devitalized tissue and absorb it into the wound pad itself. And then a treatment that was used initially for this patient was biotin silicon AG, which is a conforming foam dressing with silver as the active ingredient. And because it conformed to the wound bed, it was able to donate that silver directly into the tissues to have that really efficacy. Really, it was really effective is what I'm trying to say. I'm getting tripped up over my words. It was really effective in managing that bacterial load. And you can see from day 1 to week 14 that the wound just decreased significantly in its dimensions. The top end of the wound that you can see in week 14 has now healed. The exudate levels to the remaining open area of the wounds are now low. There are no signs of infection, and the patient's pain score significantly reduced. The wound doesn't need an antimicrobial dressing anymore and is treated with biotin silicon without silver, which again is a conforming dressing and manages the exudate that's coming from the wound really effectively. So I'm going to go back to this slide that I showed you earlier with these 6 wounds on, and I'm going to ask my colleague Charlie to come back on the call. Hi, Charlie.
Hi, Ellen. That was a brilliant session. Thank you very much.
Thank you.
We've had some good response, and everybody says that all of these wounds should be debrided.
Oh, well, I've obviously done a really good job at getting that message across, Charlie.
Certainly have. Some people have also suggested what they would maybe use for the different pictures. So some saying autolytic debridement, perhaps. some may be using biological and some using enzymatic.
Yeah, that's fantastic. And we will all have different, we need lots of different methods and tools in our toolbox for debridement, don't we? I think what we need to take into account after our assessment is the method we choose. Is it going to have the desired effect as quickly as we want it to? So perhaps rethinking about what we have in our toolbox and whether we feel confident to do that wound preparation more frequently for our patients to get the desired outcomes. Yeah. That's
brilliant.
Great. Okay. Anything else come into the chat? Any more questions?
No more questions. We've answered as we've gone along. People using different mechanical debridement aids. Yeah. No, all answered, and some really good feedback.
Thanks, Charlie. So just to recap on what we said we were going to talk about, just as a checklist really, that we did talk about these things. We need to simplify our whole approach to how we manage wounds, how we get those wounds to be where both the patient and us want them to be. You know, we need to keep things simple. We don't want things that are complex, whether that be the tools we use to assess our wounds, the methods of wound preparation that we have available to us, and the different dressings that we have to treat the wounds once we've done that really good wound preparation. We've had to talk about the different differences in different terminology around wounds preparation. Really thought in depth about why we need to prepare wounds, and I hope that I've managed to get that message across about why it's so important to remove those barriers to healing, to get the best out of the dressings that we use subsequent to that wound preparation, and to get that wound healed in a shorter time frame. We've had to think about different methods of wound preparation, what we have available to us, what might be effective for one patient might not be effective for another, but there are always different ways to achieve the same goal. We just want to get to that goal as quickly as possible. And we've thought quite in depth about the impact of wound preparation on wound healing, and had a think and a good discussion, I hope, in the chat about which wounds do need to be prepared within that wound management plan for the patient. So I'll stop sharing my screen now. So that brings us to the end of the session this afternoon. Thank you so much for joining us. As I said at the beginning, this session will be available to you to watch if you want to watch it back on the Charlie. She's just put a message in the chat on the Coloplast professional website. Charlie's just put the link in the chat now, so you know you can watch this and our previous focus to wound assessment sessions on that platform as well. And our up and coming sessions, there's another one later in the month about wound preparation. And then next month in March, we have 2 sessions, 2 webinars, which focus on the treatment of wounds within the Prepare to Heal series. So thank you again for taking the time. I hope you enjoyed it, and we'll see you soon.